At this time, Kathy Atkins, the floor is yours. If you would you please tell everyone first off and where they can submit questions if necessary?
Yes. At the end, I will have my email address on the screen so you guys can submit questions to me. But we're just going to go ahead and get started. This is part of our national series on the Prepare, Plan, and Perform for PDPM. So we decided that we're going to take you all the way back to the basics and get you started with the understanding of PDPM. So today we're going to talk about the coding impacts on the case mix index for PDPM, the history of ICD10, how the different characters in ICD10 work, and then how to code to the highest specificity. And then we're going to give you some tips and ways that you can start preparing now for PDPM. So you guys know that the patient-driven payment model is going to be implemented October the 1st of 2019, and it's going to improve payment accuracy by focusing on the patient. So we're going to have 5 case mix adjusted components based off that individual patient's characteristics for physical therapy, occupational therapy, speech-language pathology, non-therapy ancillary, and then nursing. And then there will also be 1 non-case mix index. So you guys know that diagnoses are really going to have an impact on your CMI because under each one of these categories, PTOT, speech, nursing, and non-therapy, the primary reason for the skilled nursing facility care is one of the determiners and that drives your payment that you'll be working under. So that's a big difference from the RUG system that we're currently under. So let's just get right down to the history of ICD-10. So the first ICD, and back then it was the ICD-1, started in 1900, and the main reason they did it was to track the mortality rates and the international death trends. So, and that was in the 1900s to 1909. And then it went through all these revisions, and in ICD-9, in 1979, there were revisions made and expanded to include the clinical information on illness and injury. And then we implemented ICD-10 October the 1st of 2015. And what they did was they added combination codes for symptoms and diagnoses, and it gave us the flexibility to adapt as medicine changes. So we're going to take you to the basics of it just to get you to understand it, because I think it's important that for coding that you really understand just the basics. So we know that ICD-10 is an international standard diagnostic classification, and it's used for general epidemiology, health management purposes, and clinical use. And it is used to classify diseases and other health problems on health and vital statistics, including death records. And then it gives us the basis for completion of national mortality and morbidity statistics. So it's actually the World Health Organization that has a lot to do with it. So you're asking yourself, so why is this important? We have to have accuracy with ICD-10 because, for number one, it tells the story of the patient. It gives you their history. You can look through the list of the ICD-10s that they're assigned, and you can tell medical history based off the ICD-10s. It also gives us accurate data collection. It does gather data for the national trends for the local coverage determination and the outcome, but the big one is that it establishes medical necessity. So I've got a graph in here just to show you. In 2018, they did a national trend statistics on whether people understand ICD-10. So it was implemented in 2015, so this is 3 years after it was implemented. 64.5% of people said yes, they understand it. 13.2% said they're not sure that they understand it. And then 22.4% just said, no, I don't understand it. And I think in rehabilitation, we have a lot of therapists that are in that 22.4%. So we're trying to do as much education as possible to educate our clinicians, too, on the importance of it. So just general information about ICD-10, it's 3 to 7 characters. There are 71,932 current codes in 2019. Every year, there's revisions that are made, deletions, additions, add-ons. So we're at 71,000 now. Digit 1 is going to be alpha. Digits 2 and 3 are numeric. 4 through 7 are alphanumeric. I'm going to show this to you in a couple different ways so you can understand it. It is very specific, but it allows room for expansion for the future. has laterality, so we have codes that identify right versus left side of the body. It has the possibility of identifying the initial encounter, subsequent encounter, and the sequela. That's your 7 characters. And you can report up to 12 codes on a claim form. So here it is in a little different format. So again, we've got a medical diagnosis example here. So that first digit is going to be alpha. You're never going to have a U there. So it's all letters of the alphabet, but U is an exclusion. So the second and third, that's the category. The first 3 are category. Second and third are going to be numbers. The 4th, 5th, and 6th is the etiology, the anatomical site, and the severity, and they can be any combination of alpha or numeric. And the 7th is the extension. Here it is another way to look at it, and I've actually got a ICD-10 up here so you can see S72.351. So the S is the alpha, that's the category that it's in. The 7 is the body system, so that's the body system that's located in. The 3rd is the root operation. The 4th is the body part. The 5th is the category, anatomic site, and the severity. The 6th is the same way. It's the category, anatomic site, and severity. And then the C is the qualifier. So that's your encounter code that you're going to be using. So here is the code that I use, S72.351C. Displaced communicated fracture of the shaft of the right femur, initial encounter for open fracture, 3A, 3B, or 3C, which is a classification group used for fractures. So that was 3 examples of how that one code looks in them. We also have laterality in ICD-10. It's very important that we assign laterality. So the 1 in an ICD-10 usually means it's the right side, 2 means it's the left side, 3 will be bilateral. You have 9, so the side is unspecified in the medical record, and sometimes you have a 0 for extremity-related or other diagnoses. The 7th characters are very important because if you don't code to the full number of characters and the 7 digits are required, it's going to be invalid and it's going to kick it out. We're going to show you some examples of that in a minute when we get to the return to provider. It doesn't mean that all ICD-10s are going to have 7 characters because they could have 3, so it's 3 to 7 characters. But the 7th character is used in some chapters to give data about the characteristics of the encounter. So one of the examples of that is in the injuries and fractures. So here's what the 7th characters look like. So the A is the initial encounter. So the time frame for that is the entire period when the patient is receiving active treatment. It can be used on more than just the first claim. It is kind of rare that you're going to see that in a skilled nursing facility because the more research you do on that initial encounter, it's usually in the hospital emergency room or a doctor's office. Now, if a patient fell at the facility and had a fracture right at that moment, it could be coded with an A. D is a subsequent encounter. So that's following the active phase of treatment. It means they're receiving routine care for an injury during the healing or recovery, and therapy is considered part of the healing and recovery phase. You also have S, which is the sequela. That's your late effect residual after the acute phase is terminated. It's when complications or conditions arise as a direct result of a condition, so there's no time limit on that, and that could occur months or years later. Now, there are other 7th characters in other chapters, and some of the examples of that are fractures. They may have an A through S, and they're never going to use an L. So there are some characters in some chapters in the book that you may see something other than the A, D, or S on the end of it. So that's why it's important that you're looking that up in the book to make sure you're getting an accurate 7th character. So when you have a 7th character and it's required, sometimes there's not enough numbers to fill it out. So they actually put an X in as a placeholder. So that X is in there to allow for more expansion in the future. It does fill out those empty characters when you have a code that you have 6 characters and the 7th character applies. It has to be used in order for it to be considered a valid code, and it's not case sensitive. So when you put it in, it doesn't matter whether it's an upper or lower case. And I've got a cartoon there because there's a lot of cartoons around ICD-10, so we're right in the middle of winter here. So carrot stuck in the left ear, so the code for that is P16.2XXA. So it's the initial encounter for the A, but you have to put the two X's in there to code that out to the 7th character. So here's just information about the book. That's why we're stressing the importance of getting a book so you can code from the book. There are 2 sections in the book. You have the alphabetic index, or the index to diseases and injuries, and then the tabular list. So the alphabetic index have the diagnostic terms listed in alphabetical order for the disease description, the table of neoplasms, the table of drugs and chemicals, and the external causes of injuries index. Then you have the tabular list that has them organized in a sequential order and divided into chapters based off the body system or condition. So there's 21 chapters in the book, and they all have categories, subcategories, and then codes. So here's how you actually look a code up in the book. First, you go to the alphabetic index, and you locate the main term. So you're looking, and I'll give some descriptions so you understand what the main term is. That's going to be listed in bold in the alphabetical index. It refers to the reference diseases, the condition or symptom, and is a default code. So that default code represents a condition most commonly associated with that main term. And then you have subterms that modify the main term that describes the site, the etiology, and the clinical type. So you verify that default code in the tabular list for accuracy. So you start in the book, you go to the alphabetic, then you go back to the tabular area to look under the body system that you're referring to. Here's an example, diabetes mellitus, because a lot of our patients have diabetes. It is a combination code. So it includes the type of diabetes, the body system that's affected, and any complications that affect the body. So you have to assign all codes that are needed to identify all of the associated conditions. So I got asked this question when I did the training the other day. If they have more than one issue because of the diabetes, you code all of those rather than just one combination code. So here's an example. So E11 is type 2 diabetes mellitus. That's your main term. So the diabetes is the main term. Then this is the way it looks in the book. So it includes diabetes mellitus due to insulin secretory, I can't pronounce that, defect diabetes, insulin-resistant diabetes. Then you have to use an additional code to identify the insulin, the oral drugs. And then it excludes diabetes mellitus due to underlying condition that gets coded in E08, or secondary diabetes mellitus, NEC, which goes in E13, or type 1 diabetes, which goes under E10. Okay, so I want to show you what the subcategories look like. So E11.35 is type 2 diabetes mellitus with proliferative diabetic retinopathy. So under this one, this is where you're getting into the laterality. You have to code a 7th character in the subcategory to designate the laterality of the disease. So it gives you 1 is the right eye, 2 is left, 3 is bilateral, 0 is unspecified. So that's what one looks like under the subcategory. So I wanted you to see what that note looks like. But then you can get into other type 2 diabetes mellitus with retinopathy with macular edema. And then you can get into one that has a detachment involving the macula. So that's how detailed. Diabetes is multiple pages in the book. So there's a lot to coding just diabetes. So if they don't give you a diabetes, you just see diabetes mellitus, you're going to code to a default code, which is E11.9. And I'll show that to you when I get into the case studies. So there are excludes notes in the book, and it's important that you read those excludes notes and understand what they mean. So excludes 1 means it's not coded here, should not be used at the same time as the code above when the 2 diagnoses are related. So I've got an example in here. So teeth grinding is F45.8. G47.63 includes sleep-related teeth grinding, so these 2 codes can be used together. So it's important you pay attention to these exclude notes. Exclude 2 means it's represented not coded here. The condition excluded is not part of the condition represented by the code, but the patient may have both conditions at the same time. When you see an excludes 2 note under a code, it is acceptable to use both the code and the excluded code note together. That's why coding is so complicated, because you have all these notes that go in there. So acute versus chronic, when there's an acute and chronic condition documented, if there's separate codes for each one, the acute is always going to be sequenced first, and then the chronic is added as an additional code. A Z code is used if the condition no longer exists but affects patient care or the need for the patient to seek medical attention. I've got an example of that in here to show you when we get in the case studies. I got to ask questions about signs and symptoms. So signs and symptoms may be coded if the physician has not confirmed a diagnosis yet. So you only code the signs and symptoms when there's not a definitive diagnosis. Most of those signs and symptoms are located in Chapter 18 of the book, which is Symptoms, Signs, and Abnormal Clinical Laboratory Findings. You have to refer to coding conventions, as some signs and symptoms have been assigned in other chapters or classifications. So it's very complicated with the signs. It's important that you have that book so you can look at what those coding conventions are. So this is what the table of content looks like in the book. There are 21 chapters. They are broken down by body systems. And the very last two chapters are external causes of morbidity and then factors influence health status and contact with health services. We get a lot of questions about Z codes, so I'm going to do some case studies just to show you how to code some Z codes. The conventions and guidelines are in the very back of the book. To apply diagnosis correctly, you have to understand how to apply those conventions and terms. And it just kind of spells it out how you do it. Like you heard me say earlier that E11.9 is assigned if the diabetes is not specified what it is. That's always your default code, and that's one of the coding conventions out of the back of the book. The first section gives you conventions, general coding guidelines, and then chapter specific. Here's a couple of examples of conventions. NEC, not elsewhere classified. It doesn't provide a code that's specific to that patient's condition, and the provider documented more specific information regarding the condition. So they gave you information about it, enough to know that there's a condition there, but it's not really giving you enough that you can code it to a specific code. NOS is not otherwise specified. That's the equivalent of unspecified, and I'll just caution you right up front, we need to stay away from as many unspecified codes as we can. You only use them when there's a lack of information to code a more specific diagnosis. There are some other examples in there, the coding conventions, the excludes 1 and 2 notes that I just talked about. You've got other unspecified, code first, combination codes, a lot of coding conventions in there. I think you could do a whole training on just the coding conventions. So here's your steps for correct coding for ICD-10. First, you're going to locate that main term in the index to disease and injury. So that alphabetic index, you go there first. Then you look at any notes that are under that main term, because I showed you what that looks like with the notes and the subcategories. Read any terms that are enclosed in parentheses following the main term. Refer to the modifiers of the main term. Do not skip the subterms, because there could be information in those subterms that are going to direct you, like the diabetes one directed you to another. Rather than be in the E11, you were in the E08 or the E10. And then you cross-reference the instructions. So you also, if it says see also another term, go look at that one too, because it may be more important. It could be a combination code that needs to be coded under a different one. And you may need to use a medical dictionary to help you identify the main terms and understand the disease process to make sure you're getting accurate coding. So let's just give some examples here, because I think the best thing to do is learn by case studies. So we've got 3 of them built in here to show you how to code. So for the primary diagnosis for admission to the skilled nursing facility, what is the main reason this person is being admitted to the SNF? So that's terminology that's used in both coding and the CMS guidelines. So the primary diagnosis represents the primary reason they were admitted to the SNF, which may or not be the same reason they were admitted to the qualifying hospital stay. Because if the diagnosis is resolved, you're not going to be coding that. So CMS went on to say there's no reason the primary SNF diagnosis must match the primary hospital diagnosis from the prior hospital stay. So you need to ask yourself, is the reason for the hospitalization resolved? So here's your first case study. So we have a 68-year-old male. He was admitted to the hospital for sepsis, pneumonia, and the flu. He also had a past medical history of bipolar disorder, COPD, encephalopathy, rhabdomyolysis, diabetes mellitus, hepatitis C, and hypothyroidism. So here is how the medical diagnosis should be coded on him. So the A41.52, sepsis, is your first or your primary diagnosis. So the schizoaffective disorder, bipolar, is number 2. Z59.1, which is inadequate housing. He didn't have heating in his home. J44.1 is your COPD with acute exacerbation. E11.0, type 2 diabetes mellitus without complications. Z79.84 is the long-term use of the oral hypoglycemic drugs. And B18.2, chronic hepatitis. So here's your analysis. So the primary reason for the skilled nursing facility admission is sepsis. The pneumonia and the flu were resolved in the hospital, so we didn't use those as the primary diagnosis. He also wasn't able to take care of himself due to the schizoaffective disorder, bipolar, and the inadequate housing. So those were the 3 things that were listed in there. The sepsis is coded first because it's an acute diagnosis. The bipolar is a secondary diagnosis, and the Z code supports a personal history that's going on for why he can't go home, because it's the middle of winter, so there's no heating. So the diabetes was coded as a default code, E11.9. I think I got something different in the previous slide. I'll have to look. Long-term Z code is used to identify the additional code for the oral drugs under the diabetes, so the Z79.84. The next thing, I'll show you how rehab would code this patient. So occupational therapy used Z74.1, need for personal assistance with personal care. They did muscle weakness, M62.61, because they had done manual muscle testing and identified specific muscle groups that he had weakness in. They've got G31.84, which is mild cognitive impairment, and then R27.8, other lack of coordination. Speech-language pathology coded the mild cognitive impairment, and they also picked up a dysphagia issue, oropharyngeal phase, the R13.12. Physical therapy coded R26.2, which is difficulty in walking, and they did Z81.91, history of falling, at risk for falls, because when they did their evaluation, they determined that he had had falls and he was a risk for a fall. They did not code, this is one of the excludes notes in the ICD10 manual, they did not code R29.6, which is repeated falls, because of the exclusion note under R26.2 that you can't code R26.2 and R29.6 together because of the excludes note. So here's case study 2. This one, we have a 75-year-old man who got a right hip fracture due to a non-traumatic incident. He had surgery for an ORIF, was discharged to the SNF because he lived alone and he couldn't care for himself without assistance. So your medical diagnosis on this one is S72.14D. Should be an X in there. Displaced intertrochanteric fracture of the right femur, subsequent encounter. The D is used because it's still healing. So it's not the S yet because it's pretty new, but he's not in the hospital, so it's not going to be an A. The Z47.89 is the encounter for orthopedic aftercare, and then the A49.9, he's got a bacterial infection. So the analysis of the primary reason for the SNF is that we use the 7th character of the D because he's in the active phase of treatment, but he needs rehab. So that's why we're using the D. They receive routine care for injury during the healing or recovery. He's got an infection in there, and therapy is considered part of the healing and recovery. They added an additional code for Z, the Z47.89, aftercare for the orthopedic surgery, because that's really the main reason that he's admitted to the facility. He needs rehabilitation in order to be able to return home. He did get a bacterial infection in the wound, but the review of the medical chart didn't give a specific infection, so they ended up using an unspecified code. So here's what rehab coded. Physical therapy did difficulty in walking, pain in the right hip and knee, because when they analyzed, he had pain in both the right hip and knee. OT did muscle weakness, which was supported by manual muscle testing. They did the Z74 because need for assistance with personal care. They found that he had a vision issue, H54.2, so they coded low vision. That was supported by documentation from the physician to give the okay to use that code. And then speech did not pick him up because he didn't have any cognitive or swallow issues, so there weren't any ICD-10s for speech. The third case study is an 82-year-old that was admitted to the hospital for pneumonia. Their past medical history included osteoarthritis, a right knee replacement 6 years ago, and hypertension. They live in a private home, and they have a son and daughter who live in different states, but they couldn't stay with her when she returns home. So this one for medical diagnosis, they use Z7 4.2, need for assistance at home, no other household member to render care. That can't be used as a standalone code because the Z codes, you have to code conditions with them. So we also have Z7 2.3, lack of physical exercise. Pain in the right knee, that was identified by nursing and PT on admission. That was in the nursing documentation. Pain in the left knee was identified by nursing and PT. And then bilateral osteoarthritis of the knee and essential primary hypertension. So pneumonia wasn't coded because the pneumonia was resolved in the hospital. They used the Z codes because the patient wasn't able to go home because there was nobody there to care for her and she could not take care of herself. And she had a lot of pain because after the knee replacement, she had stopped exercising. So she was having some arthritic pain. So rehab used R26.9 for PT, other abnormalities of gait and mobility. They did the pain in the right, I got some typos in here, that needs to both say right knee and hip. They also had a contracture of the right knee. That was the knee replaced 6 years ago, and they identified that there was a contracture in that knee. OT did Z74, need for personal assistance. Muscle weakness, they picked up contractures in the right shoulder and the right hand, so they have those listed under treatment diagnoses. They also have the other lack of coordination because the patient has contractures in the shoulder, so they're having problems with gross motor coordination. So just a few tips that we're going to give you on how you need to get prepared. The first tip is that primary diagnosis. Since that primary diagnosis is the reason they're being admitted, and that's going to set a lot of the payment at the facility, what is that primary reason that they're being admitted? And is the reason for the hospital resolved? You always need to ask yourself that question before you put that first code down. Look at the crosswalks that are on the PDPM website to determine if you choose a valid diagnosis, and I'll show you that in just a minute. And if the diagnosis is listed as return to provider, the diagnosis is not going to provide a PDPM classification, and the record's going to be rejected. So if you go to the PDPM website, they have a grouper interactive tool, and this is kind of what it looks like. So I kind of played around with it just a little bit. And it actually shows you what your RUGS-4 classification would be and what your PDPM would be based on what you're doing. So I went in and I assigned a primary diagnosis, and I listed that they didn't have a surgical procedure, and here's what it looked like when it came back. I picked I63.9, which was cerebral infarction unspecified. So it came back as a missing or invalid input for the primary diagnosis. So this might be a return to provider code where you're not going to get a PDPM classification. And then Liz added a screenshot in here to show you what the default clinical categories are going to be. This is just kind of a quick little snapshot for you to see. And if you look, a lot of these are the not elsewhere classified codes, which are your unspecified codes. That's why we're stressing the importance of not using unspecified codes. So tip number 2 for the NTA comorbidity score, CMS has identified 50 conditions that are associated with calculating the NTA cost in SNP patients. There is a mapping of those ICD-10s and the comorbidities used for patient classification, and they're available on the PDPM website. Providers need to identify all comorbidities for which a patient would qualify. And just a general statement here about HIV and AIDS. It's reported on the SNP claim in the same manner. It's always been under RUGS-4, but it will result in an 18% add-on. So HIV, AIDS, just the generic ICD-10 is B20. Here's an example of some of the NTA examples, just so you can see what they look like and the points that get assigned based on a point system. HIV/AIDS is the top one, and it's 8 points. Surgical history is needed to capture any major surgical procedures that occurred during the qualifying hospital stay that immediately preceded the SNF admission. You have to meet the following criteria in order to code it under J2100 and J5000. Has to be inpatient in an acute hospital, 1 day in the 30 days prior to the admission to the SNF, and the surgery carries some degree of risk to their life or potential for severe disability. Our fourth tip is accurate coding for specificity. We can't stress that enough. You need to code to the highest level of specificity. Code only active diagnosis. If it was resolved in the hospital, you shouldn't be coding it. Code to the correct 7th character. So that 7th character is based on the encounter. A is usually for the active treatment. That's usually only coded in the hospital and the MD office. Usually what we're going to use in the SNF is the D for subsequent encounter or the S for sequela. Code only diagnoses that are documented by the MD or physician. Diagnosis is documented by nurses and therapists without physician documentation are not always coded to the correct specificity. Most doctors nowadays use some kind of electronic version to code. Symptoms are only coded when the doctor hasn't made a more definitive diagnosis. And make sure you're using the correct year coding manual. So the manuals have several items that are important to coding correctly, as you heard me talking about earlier, with the coding conventions, the excludes notes, and then sequencing instructions for coding the principal or the code first, and then any additional code. Your referral sources are going to be key for getting accurate information for ICD-10 coding. It's important that you get timely and accurate information. That's going to be a must under PDPM. If you have the ability to get electronic communication from your referral sources and get that medical history timely, that's the avenue that we would recommend that you go down. And then you need to think about who at your facility is receiving the information from the referral sources. Is there a backup person to cover those 7-day-a-week admissions? Because it's going to be important that you get your coding accurate right up front. And then how is the information getting disseminated at your facility to make sure accurate information is getting to nursing staff for admission? Because nursing documentation is going to be key. So are we moving to ICD-11? I'm starting to hear a lot of stuff about it, so I just want to give you just a brief blip on it. ICD-11 is going to be a digital product. It's going to be linked with terminology. So the World Health Organization and the International Health Terminology Standard Development Organization, the IHTSDO, is working to link this together with something called SNOMED CD. So that stands for Standardized Nomenclature of Medicine Clinical Terms. So it's going to link all the terminologies and classifications together. It's going to be multi-purpose and coherent classifications by mortality, morbidity, primary care, clinical care, research, and public health. It's going to support all electronic health records and information systems. It's currently in phase 2 as of January with a joint task force. There's going to be 26 chapters, so we have 21 now. There's going to be 26 chapters. There's going to be 2 for V, which is a supplemental section for functioning assessment, and then there's going to be an X, which is the extension code. And right now the code structure of it is stable, so it's starting to be used a little bit in Europe. We wanted to provide you with some resources for PDPM and coding. If you have not been to the PDPM website, I would recommend going there. And this is what it looks like, and here's the link to it, and we'll be sending this PowerPoint out with the recording once we send it out, so you'll have it. But this is what that website looks like, and I want to point you directly to this part of it. There is a PDPM frequently asked question that is a very good document that answers a lot of questions that you probably have kind of running around in your head right now. And then the PDPM presentation that CMS did is in there. And if you go get that presentation, I would recommend going and pulling the transcript of the questions that were asked at the end of it, because there were some very good questions in that, because Medicare Learning Network did a PDPM training, and it was very good. Also, your PDPM resources, your classification walkthrough, the grouper logic that I showed you a screenshot of earlier, the clinical category crosswalk, and then your NTA comorbidity crosswalk. I would recommend that you pull this information and go look at it now. Liz wanted me to kind of end the training with how you can become coding certified, because we've gotten this question a lot. So I've got a screenshot in here from AAPC right now, and I'm not promoting any specific company, but right now they do have 50% off their coding classes if you sign up before the end of February, and the books come free, so you can actually get the books free. But here is one resource, the AAPC. You can also get through AHIMA, which is more hospital information management. So that's two that I know of where you can get your coding certification. Very involved classes. I'm in the middle of taking the CPC right now, and I've been through the whole 21 chapters of ICD-10, working through the CPT coding book now. So it's a very, very involved class. So it's expensive, but it's half off right now, so it's a good thing. So you can get it cheaper right now if you decide to do it. And like I said, the benefit is you get the books right now. So if you have any questions from this webinar or any questions, we will do our best to answer them. You can email them to me, Kathy.Adkins, KATHY.ADKINS @rehabcare.com. So that's Kathy.Adkins @rehabcare.com. And I want to thank everybody for taking time to get on the call today, and I apologize. Liz got tied up because of the weather and was not able to get on. So we will take the questions via email, and then I will get them over to her, and then that way maybe we can answer any questions that you have. And Ted, that's it. I want to thank everybody for getting on.
Thanks, everybody. Have a wonderful day now.